Good morning, everybody, ladies and gentlemen. It's a great pleasure for me to present the webinar on lung cancer screening. In this webinar, we will review the most important screening trials, and we focus on the impact of COVID-19 in the program. We will host in this webinar the most important and renowned expert in lung cancer screening. And so I would like to thank all the speakers to be here, and I would like to thank Medtronic for the great support for the organization of this meeting, and especially Mats Fredriksson and Tri Subramaniam. We have shared with me this idea to focus on lung cancer screening. I will present some introductory slides just to address the topic, the problem, and to present what we will see in this lung cancer screening webinar. The history of lung cancer screening starts in early 1970, and when some trials were organized in Europe and in the US. A common finding across all of these trials was the increase in lung cancer detection rate with a 5-year survival, ending 5-year survival, but in none of the screening there was a mortality benefit, and that was the big issue. The limitations of early lung cancer screening trial were many, such as different designs, small sample size, the fact that primarily was addressing the benefit of sputum cytology, not the X-ray, and some degree of contamination between control arm and screening arm. Among the first trials, there was the LCAP published in 1999, and then Japanese studies and US study. The conclusions of the early low-dose lung cancer screening were that detection rate was higher, 6-fold higher nodule detection rate than chassis ray, 3-fold higher cancer detection rate than chassis ray, and most of the nodules were benign nodules. The increase in resectable lung cancer was 5-fold, but there was, as told before, no problem benefit in lung cancer mortality. The most important trial who was the game changer was the National Lung Screening Trial published in 2019, which randomized over 53,000 heavy smokers aged 55, 74 years old who underwent low-dose CT tomography or X-ray, 2-arm. The National Lung Screening Trial showed an impressive reduced lung cancer death by 20%, with the number needed to screen to prevent one death from lung cancer around 320. The MILE trial by Professor Pastorino was a new confirmation of lung cancer screening efficacy, and we will hear from him about his trial, which showed a 39% reduced risk of lung cancer mortality and a 20% decrease of overall mortality. The Nelson trial has been published a few months ago in the New England Journal of Medicine, and it was a volume CT screening compared to the other that addressed the sites. They randomized 15,792 subjects with a 26% reduced risk of lung cancer mortality and 39 to 61 reduced risk in the female subgroup. But we hear from Matthias Oudkerk the true story of the Nelson trial and the less up-to-date. Very recently, in July, this year July, the United States Preventive Services Task Force reviewed the criteria for lung cancer screening compared to the previous criteria. You see, the age was enlarged to the range 50 to 80 years old, and the smoking history was 20 pack year instead of 30 packs year that was the previous standard. You know, it's very important to review the clinical status of the patient and to make a checklist before to select patients for screening. Which are the questions open for screening? First of all, who should be screened for lung cancer? There are standard criteria, risk calculator, much more. And what are the potential harms of lung cancer screening? Radiation exposure, of course, the number of invasive procedures, incidental findings, and an overdiagnosis rate that could be roughly 10 to 20%. If we take care of the radiation, we see that the medium absorbed dose is 1.4 millisievert. That is much less than a standard diagnostic CT that is around 7 millisievert, but it's much more than one chest X-ray, of course. So we have to, so even the number of false positive nodules can be even high, and some of the recent trials have cut this false positive rate. Then the overdiagnosis, that is estimated to be at 10 to 20%, and radiation exposure are very, very important. But of course, what can I say to people is that the best way to lower the chances of dying from lung cancer is to stop smoking. More than 8 out of every 10 lung cancer in the United States are from smoking. So I think that we have to teach smokers that quitting smoking is the most important practice they have to do. And the centers for smoking are very important for this, for the prevention of lung cancer. Thank you very much. At this, after my introductory slides, now it's the time to start the meeting, and so I please ask to Anna Rita Larici, which is from the Catholic University of Rome. That she's a radiologist, and she will present the key points in lung cancer screening from the ERS statement. So it's a statement of the European Society of Radiologists and European Respiratory Society that have addressed the lung cancer screening. Please, Anna Rita.
So thank you, Giuseppe, for your kind introduction and invitation to this webinar. So it's not a news that lung cancer still represents a big killer all over the world on both male and female. And it's not surprising that lung cancer screening trials have enrolled more than 100,000 participants worldwide in the last 2 decades, and this number is designed to increase further over years. In these slides, I show you the positive results in terms of reduction of lung cancer-related mortality in the most relevant lung cancer screening randomized trials performed with low-dose CT versus chest radiography in national lung screening trials and Japanese trials, and versus control group of participants that did not receive any diagnostic tests versus screening group with low-dose CT, published in 2020 in the Nelson trial, and also in the long-term trials, the mild trial published in 2019. And as you can see, we can say that lung cancer works well and fulfilled is a main objective, the objective of all type of screening trials. And with the attempt to improve lung cancer screening programs on the basis of the recent developments in this field and discuss the unmet needs still present, the European Society of Radiology and the European Respiratory Society published a white position paper that has several relevant key points that I summarized in these 4 points: the relevance of participants' involvement, the selection of participants, the quality assurance, and tobacco cessation. So regarding participants' involvement, it's quite clear that the success and effectiveness of a screening program strongly depends on the proportion of at-risk population engaged into the program, and that communication and collaboration between healthcare providers and screening participants can increase the effectiveness of lung cancer screening, allowing to reach a true shared decision-making for screening participants that participated to these statement papers. This is a quite new approach. And therefore, we have to concentrate in patient-centered shared decision-making and adequately inform participants on benefit and harms of screening, because this would represent standard care. And to perform and to reach this level of standard care, it's necessary to plan and to engage a multidisciplinary team in which participants will be chest radiologists, thoracic surgeons, oncologists, pulmonologists, and so on. So that's the first point that I would like to underline regarding this statement. Regarding selection of participants, again, the effectiveness of lung cancer screening increases with the population's risk of lung cancer. But this was not a result of national screening and trial published in the USA, performed in the USA. And so the question is, should we consider only age and smoking history rather than other factors that can affect the risk and determine the risk of lung cancer in the context of this project? So the proper selection of participants in lung cancer screening trials has emerged as a significant area for improvement. And as you can see here, age and smoking history were the selection criteria to enroll patients. And as you can see, the cancer rate per year was less than 1% in both experience. So risk prediction models are needed in this context because these models can be helpful in selecting adequately individuals with increased pretest probability of having lung cancer. And this is a summary of risk prediction models published in literature so far. Here, the list of risk factors, and you can see here also the relevance of underlying disease such as COPD, personal history of cancer, family history of cancer, and so on. And the two most complete, I think, that are Liverpool Lung Project risk model and the PLCO models. And as you can see from these summary, these two prediction models have been used in the pan-Canadian screening trials and also in UK lung screening trials. As you can see here, the cancer rate in both cases was higher than 1% per year, and the cumulative incidence that was possible to be calculated only for PanCan studies were after 5.5 years was 6.5% greater than those reported in the NLST and Nelson trials. For UK, it was possible to assess only baseline prevalence, but again, greater than 1%. So this means that prediction risk models increase screening effectiveness, increasing significantly sensitivity and positive predictive value, as you can see from this data. Furthermore, always thinking about effectiveness of lung cancer screening project and program, we have to say that these two studies demonstrated, long-term studies demonstrate that prolonged lung cancer screening reduce 10-year mortality, both the MILD trial and Nelson trials. And particularly after going beyond 5.5 years and 6 years since the initial randomization. And again, this is a method to increase screening effectiveness. But what about quality assurance? When we perform lung cancer screening, we use low-dose computed tomography, and we have to keep radiation dose as low as reasonably, but on the other side, ensuring sufficient quality of our images to accurately identify nodule, particularly subsolid nodule, that show a very low density with respect to the adjacent lung parenchyma, and also to accurately measure and therefore manage these nodules. And modern CT scanners allows to perform iterative reconstructions that reduce the noise at the level of image and improve the so-called ratio among signal and the noise at the level of images. Therefore, we can use ultra-low dose CT going down to 1 millisievert of radiation exposure to the participants. That's an important point. And as already underlined by Giuseppe, we can say that nowadays an ultra-low dose CT deliver a dose that is quite corresponding to one flight going from Europe to Japan and going back, with respect to 7-8 millisievert per scan of the traditional diagnostic chest CT. We have to keep in mind that also in our routine practice, we are trying to reduce our dose, the dose at on CT scan in reference to the European new rules in this context. In the context of quality assurance, it's important to define a positive test result. There is a high variability in assessing a positive test results in different trials. And in the NLST, positive test was considered a test with a scan with a nodule greater than or equal to 4 millimeters, and only diameter was considered to assess the positive test. But the consequence was a high percentage of positive test results in all screens, and also subsequently a false positive rate very high. But Nelson, that's why in Europe another approach was established for the Nelson trials, published 10 years later than NLST, and in which volume was considered for assessing the positive test results. That was considered a nodule greater than 500 cubic millimeters, or considering the follow-up, a volume including between this data or and a 25% growth at the 3-month follow-up. But the most important thing is the reduction of percentage of positive in all screens to 2.7%, and the reduction of false positive results approximately to 50% by using volumetry. And that was an important point to consider. We have to say that there have been different definition of a positive screen result according to different guidelines on the basis of dimension of the nodule, appearance of the nodule on CT, resulting in different management guidelines. And so we have to keep in mind that there are several guidelines, different algorithm, and we are still discussing on this application, and in the photo standardized interpretation, reporting, recommendation for management of this nodule, diagnostic algorithms have been validated, particularly LANGRADS, and also the European guidelines that embrace British Thoracic Society guidelines that including volume assessment to evaluate the positive, indeterminate, or negative results. So we have also to consider that the expertise in reading CT is very relevant. So chest radiologists might increase the risk of malignancy evaluating the density, margins, location, and shape of nodules. So this is a relevant point that we have to consider in addition to nodule appearance, nodule density, appearance, and dimension or volume. So important point. And radiologists might be assisted in reading and interpreting medical imaging by using computer-aided detection and diagnostic algorithms that are helpful in characterization, that means in increasing the likelihood of malignancy of a nodule, and also in performing volumetry, so in assessing the volume of the nodule at the baseline, and also growth rate and volume doubling time, that are very helpful in addressing management of this lesion. In fact, CAD increase the sensitivity significantly with respect to double reading of CT for any nodule, but when we consider nodule with the bigger, with a diameter greater than 50 cubic millimeters, we can have also a significant reduction in false positive results. And the performance of a CAD is established and is assessed by sensitivity and false positive examination. And look at also the positive predictive value in detection in increasing the risk of lung cancer and detection of nodules that are really lung cancer. Positive predictive value is of the CAD system is of course not so well with respect to the visual assessment, just for the reason that I underlined before. And for non-solid and part-solid lesion, this is a very interesting paper from Mario Silva, demonstrating that CAD increases sensitivity in evaluating this kind of nodules with respect to visual assessment, with an interesting reduction of false positive examination that you can see here, that we expect also to have in the future. But also now I have to say that artificial intelligence and in particular deep learning algorithms are very helpful in this context to reduce the false positive results, and also of CAD, I mean, and also it's relevant to consider that we are moving toward automatic pulmonary nodule management in lung cancer screening with deep learning algorithms that are helpful in classifying nodules type relevant for nodule workup. You can imagine how this can be helpful for us in reading and in determining the management of these lesions. So CAD has several advantages for nodule detection. Combined CAD and volumetric thresholding assist CT lung cancer screening, and this combination improves sensitivity of pulmonary nodule detection by CT and increase the positive predictive value for cancer detection working together. And so it's important also to underline that in this context, European Society of Thoracic Imaging organized certification project for increasing the quality assurance in lung cancer screening programs. And this is as a sort of implementation of these this should improve the implementation and the use of lung cancer screening programs all over the Europe. So you can see this in this site, in our site, the content of these certification project. And so at the very end of my presentation, just to keep in mind that this statement was held because to improve and to increase the lung cancer screening project and programs in Europe, and also stimulate Europe's healthcare systems to facilitate and to allow citizens to benefit from organized pathways. So the effort is this, for early diagnosis of lung cancer, and of course the need to implement large-scale programs. So I would like to thank Professor Lorenzo Bonomo and Mario Silva for their valuable contribution in implementing lung cancer screening project and also programs in at the national and European level, and also my friend Paola Franchi for continuing to support us in our program, our lung cancer screening program in Policlinico Gemelli. So thank you very much for your attention.
Thank you very much, Anna Rita. A very clear presentation. I really appreciated was your take-home message regarding the need for set up and implement large-scale lung cancer screening program in Europe. And in this step, we are a little behind US, so we have to overcome this gap. So now we invite to talk Dr. Phil Crosby from Manchester. He will talk about implementing lung cancer screening, Manchester's lung health checks. Thank you, Phil.
Hello there. Can you see my screen?
Yes.
Okay. So thank you very much for inviting me to talk. It's a real privilege. I'm a chest physician in Manchester, and my talk today really is just to give you an overview of our approach to the implementation of lung cancer screening. Manchester is an area of quite high socioeconomic deprivation. And that means that the incidence of lung cancer is very high. And the graph I have here on the left of the screen just shows that North Manchester and South Manchester actually are, unfortunately, top of the tree when it comes to lung cancer incidence. So it's a massive problem locally. And that's, as I say, due to that combination of smoking and deprivation. The issue with lung cancer, though, is it's not evenly distributed. And that's why we have the problem in Manchester. It's very much associated with deprivation. And the graph on the right shows how that relationship is. The incidence of lung cancer in the most deprived quintile is over twice that in the least deprived. That's important because, unfortunately, deprivation is also associated with less likelihood in attending health services and indeed in attending screening. So the question is, when you're trying to implement a program, how do you actually design your program to reduce barriers and encourage attendance in those who are most at risk? And there are various push and pull factors when people are deciding whether to attend a screening program or not. But what the research finds is that actually practical barriers are those that are most commonly cited. Simply travel to the hospital, paying for parking at the hospital, that really does put people off. So when we came to decide how to deliver lung cancer screening in Manchester, we wanted to address these barriers to ensure that the people who are most at risk could actually attend. And so we came up with a lung health check proposal. And the key design features of that included making it broader than lung cancer screening. So we weren't scaring people with the word lung cancer up front, locating it in areas that are highly deprived and therefore have a lot of lung cancer, using services that are taken to people. We don't ask people to come to us, we take our services to them. We also target, we've heard about risk assessment and the benefits of that. So we used a risk assessment approach with the calculator PLCO. And then we also had immediate access to CT. So people came, had their lung health check, and if they were high risk, they were able to have a scan immediately on a mobile CT scanner. So our baseline round was in 2016, and we sent out invitations to people aged 55 to 74. And as I say, in 3 very deprived areas of Manchester. And we were very surprised to find that the people actually, it was an incredibly popular service. And so there were thousands of phone calls and we filled all the appointments very quickly. So in the end, we did 2,500 lung health checks. The lung health check itself included an assessment of symptoms, spirometry, smoking advice, and lung cancer risk assessment to make it more holistic. The people with a high risk then went on to have an immediate low-dose CT scan, and then they were also eligible to have a CT scan a year later. So the results of the lung health check, first of all, the people that attended were from highly deprived areas. So 75% of attendees were from the lowest deprivation quintile, half from the lowest deprivation decile. 1 in 5 people had airflow obstruction, but no prior history of COPD. So we were able to say that we were having early detection of COPD, and the majority of those people had symptomatic disease. We also addressed cardiovascular disease risk, and about 1 in 3 people who attended screening were high risk for cardiovascular disease, but were not taking a statin as recommended in national guidelines. So this was also a way, a teachable moment really, to address not only lung health, but also cardiovascular health. We did not have an integrated smoking cessation service in the pilot. We signposted people, and the quit rate at 12 months was 10%. But we asked people what the lung health check made them think about their smoking, and the vast majority was positive. There wasn't really an evidence that people were smoking more because of screening, which was very reassuring. In terms of cancer, we detected 1 lung cancer for every 23 people screened. That was 3% in the first round and 1.6% in the second. 80% were early stage and 90%, and screening adherence was 90% between round 1 and round 2, which was excellent. The graph at the bottom left simply shows the stage distribution in screening in orange compared to what we see in Greater Manchester in blue. And as you can see, as would be anticipated, screening leads to a very significant stage shift. Our service was not a research study. This is a clinical service integrated into the National Health Service. When we had findings from the CT, then we had thoracic radiologists who were employed within the service reporting scans. In the first round, our indeterminate rate was 14% and positive rate 6%. And about half of people in the positive group, defined as those who had to come into the clinic to be assessed further, had lung cancer. Performance in the second round was improved, so the number of nodules requiring surveillance was much lower, and the positive rate was also lower, and there were no interval cancers. The false negative rate in the first round was 0.4%, and sensitivity of 89%, specificity of 96.7%. Interestingly, 2/3 of lung cancers diagnosed in the second round originated from a negative baseline scan. Treatments, we had 63% of people had surgical resection, which is 4 times higher than the UK average, and 90% of people were offered a potentially curative treatment. We had 1 death within 90 days of surgery. So again, totally transforming the usual presentation of lung cancer, the usual treatment of lung cancer. By taking screening to deprived high-risk areas, we found that our detection of lung cancer was higher than had been reported in both NLST and Nelson, possibly about 3 times higher in the first round and double in the second round. When we then corrected that, we looked at people who were just eligible in Manchester NLST and compared it to NLST. The Manchester population still had more than double the amount of lung cancer. And presumably this is a difference within the populations themselves. One measure, for instance, in Manchester, 70% of people had left school by 16. In NLST, that figure was 6%. And this probably just represents a healthy volunteer effect in research studies that you don't necessarily get when you implement it in the real world. The risk, as I said, we've used the PLCO risk score, and these graphs simply show at the top the distribution of CT scans and lung cancers according to PLCO score, and at the bottom the number needed to screen to detect one cancer according to each score. So at a PLCO score of 1.5 to 2, we needed to screen about 70 people to detect one lung cancer. But when you got to risks of between 7 and 10%, then really we only had to screen 10 people to find lung cancer. And that raises an important question about risk model calibration. The PLCO model, our median score was 5%, and that means that we were anticipating, based on this score, 71 lung cancers after 6 years. We detected 62 cancers in 15 months, suggesting that the PLCO model may underestimate risk in the Manchester cohort, but more work is needed. Further research we did looked at the health economics, and our approach was cost effective. And that we also undertook a participation survey, which showed that people reported that the location in the community was important. And indeed, a fraction of people would have reported less likely to attend a hospital-based service. And that was particularly the case in smokers and those from the lowest deprivation quartile. So what are we doing currently? So what I've just discussed there was our pilot. That was 2 or 3 years ago now. We've had further funding to expand the service now across the whole of North and East Manchester. So this is a region of Manchester. We sent invitations to about 36,000 people aged 55 to 80 in that area. The first screening round, fortunately, was just before COVID. The second screening round was delayed because of COVID, but we restarted in August and are continuing to screen. And we have funding for 3 annual screening rounds. Modifications compared to the pilot include using ultra low dose CT. We have now immediate access to a smoking cessation practitioner. We've integrated research, and we're using computer aided detection. So we've done about 4,500 baseline scans, and the second screening round is ongoing. As I say, we've made some changes because of COVID, understandably, social distancing, etc. And it has taken the edge off the attendance, but not too significantly. There's still good numbers coming back for their second round scan. In terms of how this works, the scan is taken in a mobile van in a community. The clinical data is inputted directly onto the electronic patient record that then comes back to the hospital. The scan, of course, also comes back to the hospital. We have a NHS consultant radiologists who are specialists in thoracic oncology reporting the scans. Scan results and data then go to the respiratory physicians who take ownership of all of the results and indeed any diagnostics, etc., from the screening service, for diagnoses of lung cancer. But also we take ownership of other findings, vascular findings or other lesions as well. The Manchester approach, the results were very encouraging, and therefore NHS England have funded a much larger scale rollout across England. They've invested £70 million in lung health checks at a number of sites across England. This will be biennial screening over 2 screening rounds and is due to scan approximately 60,000 individuals. There's a national protocols to standardise approach and screening eligibility criteria. It will use both PLCO and LLP. There are different approaches in the UK in terms of how to deliver screening. In Manchester, we do screening in the community. Other sites do screening in a hospital. And then there's also differences in terms of the initial lung health check. We do a one-stop shop where people come and have their lung health check and also screening in the same appointment. Others have it where the invitation goes out and people phone to have a telephone triage and then attend an appointment later to have their health check and scan. I'll just finish very quickly by saying that we are undertaking the Yorkshire Lung Screening Trial. I'm co-chief investigator with Dr. Matt Callister in Leeds, and this is a study in the UK looking at really prospectively assessing the different ways to recruit to screening NLST, PLCO, LLP, to see which one is most effective. And really, we also have an unscreened control group just to have a look at a population level as to the impact of screening. This is just really what happens to patients when they come on the truck. It's a mobile scan in Leeds, and the study includes the lung health check, spirometry, smoking cessation practitioner, and scan. So very similar to how we anticipate screening will be implemented. We're also doing a stop smoking study, randomized controlled trial in that study, and in that study we'll be using imaging from screening to see whether that helps promote smoking cessation. So to finish my talk, the summary really is that lung health checks, stroke lung cancer screening are being rolled out in England as a large-scale pilot. We have designed them to address leading causes of premature death and morbidity, so that's early detection of lung cancer and COPD, but also prevention of cardiovascular disease and stopping smoking. We have come up with a sort of a community-based service to reduce barriers to participation, and this is one approach, but that clearly doesn't have to be the only approach. Prospective studies are being undertaken to see how best to select people in the UK, and of course we try as best we can to integrate research alongside the lung health checks, because these provide an invaluable opportunity to improve lung health checks and screening outcomes. So thank you very much for listening.
Thank you very much. Thank you very much, Phil. Very interesting presentation. Thank you again. Very interesting, the problem of the selection of patients that you have addressed very well. Now it's my pleasure to invite Professor Ugo Pastorino to take his presentation, and it's a great honor. Thank you, Ugo, and it's up to you.
Thank you. It's a great pleasure for me as well. Let's see if we can have. Can you see the slides?
Yes, yes, please.
Okay.
Perfect.
Excellent. Of the three studies, randomized study that published positive results for screening, the MILD trial different in terms of length and also in terms of selection of the screening methodologies with the different intervals. We observed a slightly larger reduction, which reached the significance despite the smaller number of participants, because we extended the screening beyond the 5-6 years. In general, we have approached the screening in the last 20 years with a individual risk profile methodology. So deciding on the basis of a baseline CT, which was the optimal interval, to adopt an active surveillance program to avoid resection of indolent disease, using indolent disease such as non-solid lesion as a marker of risk, and also other criteria such as FEV1 and CRP. And also we implemented active smoking cessation by chemoprevention with the drug. Our attempt to use a blood biomarker was to improve the risk profiling that was possible to achieve with the other radiomic and blood markers such as CRP. In fact, last year we published the results of the randomization of the MILD trial concerning annual versus biennial screening for baseline negative LDCT. So the risk modulation approach achieved just the same lung cancer mortality reductions. The numbers, of course, are small, 1,000 individuals per arm, but this is a strong evidence of an equivalence that will be tested in the next much larger European studies. The BioMILD studies that started in 2013 tried to use the results of baseline CT and blood biomarker at baseline to select a group of low risk individuals to be sent to 3-year screening repeat, and also with the aim of revealing a potential damage in those individuals that were sent to 3-year repeat. We adopted in the BioMILD trial a much narrower, let's say, threshold scheme for volume. So we moved to 113 square millimeter as a threshold for negativity, and we consider the positive lesions above the 260 square millimeters. So the range of indeterminate nodule was very small. As you see, 7% of individuals fell in this, while almost 90% were considered negative at baseline. Of interest, these cutoffs that we adopted in 2013 were then accepted by Langrads in 2019, so the last year. Many biomarkers could be used at the time. We adopted blood, as most studies in screening use blood, and we used the microRNA. We developed a microRNA signature, which we call the classifier, using 24 microRNA. This was trained in a pilot study of 1,000 individuals, validated in the MILD trial on 4,000 individuals, and we classified upfront individual in a high, intermediate, and low risk. In the BioMILD, we registered almost 10,000 individuals, of them almost half eligible, and we enrolled finally 4,119 individuals. The results that I'm presenting here were presented at the World Conference in Barcelona last year, and they show that we divided this population in 3 groups. Almost two-thirds fell in the double negative population, so negative Mirna legacy CT. One group of about 1/3 in the one positive, and only a very small proportion fell in the double positive. Of interest, the characteristics of these 3 populations were identical. So on the epidemiological base, they were the same population. But of course, the outcome was very different. And as you see, the 5% of individuals with double positive have a 36 times higher probability of lung cancer, while the single positive have a 6 times probability. A similar profile was seen for lung mortality, but what is interesting, in the double negative, we virtually had no deaths in the first 3 years. We implemented the surveillance in this study, and the surveillance of subsolid nodules, which were 225, so a very significant number of subsolid nodules, only revealed a small percent of a cancer, and not a single death from lung cancer developing from a subsolid nodule. Of interest, the proportion, the risk of resection for benign lesion that was already below 10% in the MILD trial fell to 4% when in the BioMILD using PET and microRNA as a differentiating in the differentiating process of indeterminate nodules. Through the BioMILD, we have developed a complex mixture of specific markers of individual damage that goes from the radiomic markers to the CRP, FEV1, and microRNA. We are actually working on this algorithm through artificial intelligence methods to develop an algorithm that combines radiomic risk with the other risk. The SMILE trial, that stands for Screening in Multiple Intervention on Lung Epidemics, where lung epidemics means lung and other cancer plus COPD plus cardiovascular, is what is also defined as a big three disease profile. And the basis for this SMILE trial was that we know that lung cancer only represents 20% of deaths in heavy smoker, current smoker, and 10% in former heavy smokers. So there are many major other causes of death that we needed to approach. We have already demonstrated that quitting during the screening reduces mortality, and also that high CRP infers a very high risk. But the high CRP, in principle, could be modified by chemoprevention. So we designed the SMILE as a double randomization with a factorial design. The first randomization is counseling versus a citizen. The second randomization is counseling versus aspirin plus diet modification plus exercise. We implemented in this trial the dual source somatome, the one that already Matthias referred to, a machine that allows essentially a very, very significant reduction of the dose, and you can actually run a 15-year screening with the dose of the conventional CT. We also tested 4 different protocols of ultra-low dose CT. This study has been terminated and will be published. On the basis of this, we selected the best of the 4 ultra-low dose CT programs to be implemented in the SMILE trial. Why citizen? Because the citizen is a natural compound, essentially is a galenic production, is being used for 60 years in Europe, is a partial agonist of the nicotine receptor alpha 4 beta 2, and has excellent tolerability. Unfortunately, the SMILE trial had 2,000 individuals planned, and we had 3,000 recruited. When we started the randomization in July 2019, and we had to stop in March 2020 because of COVID. At that time, we have more than 1,000 individuals randomized. We have restarted in October, so a month ago, with swab protection, and we plan the first analysis of this trial concerning particularly the trial, the smoking cessation with cystine, by March 2020. I would like to spend a few words on the COVID-19 opportunity. I mean, we have used the SMILE population during the stop imposed by COVID-19 to test the possibility of monitoring contacts by serology, tracing late pulmonary damage. This study has been, partially published, and you may have heard of the rumors that because recently in the last days, showing that there was a proof of a contact with COVID in this population already in September 2019. But what is more important, we use this data to implement swab-protected cancer detection. We started with a rapid antigenic swab. This is a test that has been already, verified by several population. In Italy, it has been selected by the Veneto region as a main, instrument to control the spread of the disease. It has a very high sensitivity and specificity of 99%. It can be completed in 8 minutes, and it only costs 12 euros. So we have restarted the screening program in October, testing with this rapid antigen swab every individual before doing the CT scan. This because an obvious goal, which is restarting mass screening in a protected environment, and also protecting the personnel in the hospital. Matthias already presented the European the Horizon 2020 program. Is a program that includes 6 European countries, not all doing the same thing. The ambitious goal is to recruit 24,000 individuals. We participate with the Howard Institute, and we hope other institutes in Europe to join this consortium. So this is my last slide. Prevention is adding something to screening, and we believe that adding screening to prevention can reduce all-cause mortality, not only lung cancer. Personalized screening is a way to improve the use of the resources, reduce costs, and target the screening according to the individual risk. But what is more important for us, we can use the individual risk to implement the primary prevention and convince individual that their level of risk justify any effort to quit smoking. I agree with Matthias Hoodkirk that now the role of biomarkers and liquid biopsy must be proved by randomized controlled trials, and we hope that in the context of the European Horizon 2020 consortium, we will be able to start a randomized trial testing the value of blood biomarker in indeterminate nodules, not probably in the entire population. Thank you very much for your attention.
Many thanks, Hugo. Many thanks for your presentation. You have answered some of the open questions in the lung cancer screening. And now I would like, first of all, to ask to the audience to make question to the function question and answer. And so at the end of all the talks, we can have the time to answer the question. So now I leave the podium, it is a virtual podium, to my friend Alan Sue from Hong Kong. He will talk about observation from China. Thank you very much, Alan.
Okay, thank you very much, Giuseppe, and so greetings from Hong Kong. So I've been asked to speak about lung cancer screening, some observations from this part of the world, from China, and I'm pretty sure you'll find it interesting because some of the insights are really quite different. Now, lung cancer screening in China has been going on for quite a number of years, and different screening programs and studies have been done over the last 20 years at both the city level and at the provincial level, not at national level though. And there's been quite a lot of experience. Now, there's a good reason for that. There's a good reason for a lot of interest in screening in China, because simply the country is so big that if effective screening is done, it's been estimated that the life years gained over the next 20 years runs into the millions, and the number of deaths that you can potentially reduce is going to be huge compared to almost any other country. So there's a lot of incentive for screening to be done in China. Now, what has the experience been in China through all these different studies that have actually been done over the last 20 years? Well, I've simplified it to 3 points, which I think will be quite contrasting with what you see in Europe. The first one is we have a different definition of high-risk patients who should undergo lung cancer screening. And let me explain. Now, if you go by a lot of the Western guidelines, I'm using the NCCN guidelines here, but you've already heard from the previous speakers, a lot of the guidelines in Europe are more or less the same. And most of the Western guidelines focus the high-risk group on an age over 55 years old and a long smoking history. These are the bedrocks of a high-risk definition. However, if you translate that into Chinese studies, it's quite a different picture. First of all, we have different risk factors involved. This particular study, for example, in Hong Kong, actually identified cooking as a risk factor. As you probably, a lot of you know, a lot of Chinese women, housewives, they cook in a high greasy environment of a lot of fumes, and that's already been identified as a risk factor. But also within this study, if you look at the two factors identified in Western studies, age and smoking, it's a different profile in Chinese patients. A lot of our patients are much younger than Western populations getting lung cancer. And a lot of our patients have never smoked. In this particular study, 76% were never smokers. Here's another study done in Shanghai. And again, they included never smokers within this screening program. And what they found was the detection rate amongst non-smokers in Shanghai was even higher than amongst smokers. So this goes completely against how you define high risk in Western screening programs. Here's another study, again done in Shanghai, about hospital workers. And they looked at the change from 2008 to 2017. And they noticed that the incidence in women increased significantly for lung cancer. But more importantly, the proportion of non-smokers has grown from 44% to over 69%. And at the same time, the proportion of patients aged 40 years or younger is now increased to 8.6% by 2017. So it's a completely different high-risk population we're seeing in China. And this study, I think, is very telling. This was published fairly recently in Annals of Oncology. And again, they identified different risk factors for lung cancer screening. And if they follow these risk factors, they found a bunch of people with lung cancer. But importantly is this line here. Of the lung cancer patients detected by screening, if we had followed the National Lung Cancer Screening Program, the guidelines suggested by NCCN, only 32% of the subsequently confirmed lung cancers would have been detected. So clearly, in this part of the world, we cannot blindly follow the Western high-risk definitions. And I think this prompts a little lesson to us that in defining high-risk populations, there might be a need for regional considerations. Now, the second lesson I think we learned from China is what's the significance of screening detected lesions? Now, again, the idea here is the concept of overdiagnosis. As we all know that if we do these CT screenings, we're going to be detecting a lot of these tumors, which are probably indolent. They're very slow growing. You might die with them rather than of them. And therefore, it's important to select those tumors which actually progress into lung cancer. And we've heard a lot about that in the previous talks. There are various ways to do that. Most of the guidelines today, if you see a screening detected lesion, you look at the size and the density, and that determines just one thing, the follow-up CT interval. So if you look at something like the NCCN guidelines, the first step is always just further imaging. There's no call for any intervention based on the first round of screening. Now, this is a very sort of passive, a relatively conservative approach based on the fact that you identified most of these are probably benign. Now, does this really apply in China and in East Asia in general? Now, if you look at it, actually, a lot of studies coming from East Asia show you that if you try and determine natural history based simply on size and solidity, it's not always that reliable. This is a study from Japan. It's not that differentiating. And if you actually look at some of the actual data from China and Greater China, including Taiwan, if you actually operate on these GGO lesions, this is what you find. If you're thinking that you can differentiate between a carcinoma or not based on density, it's not that reliable, because even amongst pure GGOs, you're finding invasive adenocarcinoma in a significant proportion of patients. Here's another study from mainland China. It's a bit smaller study, but nonetheless, what they're finding is a lot of these GGOs, which have a high GGO, it's a low solidity, there's a lot of invasive adenocarcinomas, and you cannot tell that by size alone. Even if it's less than 10 millimeters, you cannot actually tell if it's going to be benign or malignant. So in this part of the world, some of these screening detected GGO subsolid lesions might have to be treated slightly differently. Now, this is an interesting study. Again, we're going back to different selection criteria in the screening program in China, but these are results in the first round of screening. Now, detected lesions on the first round only, not on interval screening, but they were assessed by 3 experienced experts. And if they were determined to be high risk for lung cancer, some of these patients actually underwent surgical resections. And when you do the surgical resections, a lot of them, the vast majority of them, turned out to be invasive adenocarcinoma or squamous cell carcinoma. So probably these screening detected lesions might have a slightly different profile in our part of the world. I don't think the data is strong enough yet, but there's still a suspicion of that. Here's another series published from Taiwan. Again, their national lung cancer screening program in Taiwan, where all participants were never smokers. And yes, the detected lesions amongst these 10,000 plus patients, there weren't that many. Some of them, 3.2%, had an invasive procedure after screening by an experienced MDT. But if those patients received invasive procedure, over half of them actually turned out to have malignant lesions, or lesions more malignant than adenocarcinoma in situ. So it's potentially a different profile. Now, at this point, we're thinking, well, how can we better differentiate? Now, we've already heard that volume doubling times and new different markers potentially are going to be becoming available and being utilized. In future, we're going to be using liquid biopsy and biomarkers. But at the current moment in time, all we have other than the impression of a radiologist is maybe frozen section. And frozen section actually for these subsolid nodules, as you can see, are pretty good in terms of accuracy at differentiating these lesions. Now, are you going to be subjecting a lot of these patients to surgery then? Should we be advocating for a more aggressive surgical approach? That's arguable, but there is a school of thought in China and in Far East that goes along these lines. If you have a screening detected subsolid nodule, as you know, if you do surgery for them, even if you do a non-anatomical wedge resection, the 5-year survival rates can go up to 100%. Now, you might say that this is over-treatment. You shouldn't be taking these out. But the counter-argument is this: not all surgery is the same. If you see a subsolid lesion today, you can take it out by a uniportal wedge resection. It takes half an hour. The patient goes home in less than 24 hours. There's 0 mortality, and you have 100% 5-year survival. But if you choose to sit on these lesions and sit and wait until the volume doubles or becomes bigger, then the surgery you're going to be doing tomorrow is not a uniportal wedge resection. It's going to be a major anatomical lobectomy with a 5-year survival rate that is not going to be 100%, and with an operative mortality that's not going to be 0%. So this leads to the concept among some surgeons in China, I'm not advocating this, but some people think that we're moving on to minimally invasive surgery 3.0. Now, what do we mean by that? Minimally invasive surgery 1.0 is reducing surgical access trauma by VATS. Minimally invasive surgery 2.0 is minimizing the extent of resection by doing sublobar resection. Minimally invasive surgery 3.0 is reducing the morbidity of the patient over his lifetime by timing your surgical strategy. Doing a surgery, minimally invasive surgery today is going to potentially be better for these patients than doing a more invasive procedure 2-3 years down the road. So there is this school of thought. I'm not saying this is right, but some people are arguing for it. Now, the third lesson I think we've learned in China are some of the challenges in implementation of screening. I think there are many challenges here, but I just want to focus on 2 points. The first point is in terms of how do we finance this? And we've already heard about this from some of the previous speakers about how to implement a program. Now, what we've seen in some of these studies in China with screening is that if you try and implement a program, you pay for it, you open it up, and you try and recruit high-risk individuals, the response rate can be suboptimal. So after 2 years and after 2 rounds, the compliance rate for follow-up CT can drop to just about 70% or less. In fact, a more recent study published earlier this year in Henan in China, the participation rate was as low as 40%, which is really quite feeble if you're really trying to reduce lung cancer mortality through screening. Now, what are the reasons for these poor response rates? People have done analyses and they've identified things like cost, or more importantly, and quite worryingly, distrust in doctors. There's a lot of misinformation or false perceptions about what screening can or cannot do. So there's a lot of barriers. And although this is China, you can probably identify some of these factors in other countries, for example, in Europe. Now, what's special in China, though, is how we get around these concerns. And one of the unique things we've noticed in China, at least I've noticed in China over the last 6-7 years, is this. Instead of implementing screening from top down, the government or a hospital implements it, it's actually from bottom up. What the communist government has done is just mandated that these CT scans, low-dose CT scans, can be very cheap. You can actually do it for less than $50 in China. So any patient can walk into any hospital, say, I think I have high risk. I demand to have a low-dose CT. I don't care if I'm not in your high-risk definition. I just want it. He pays $50. He gets a CT scan done the same day. He gets a report that afternoon. And this is what we call self-screening. So you bypass this top-down approach and open it up to the public. And they think, if they think they're high risk, I've cooked a lot. Some of my family members have lung cancer. I can get the CT screening done. Now, there's a little hard data saying how this works. But one thing we've noticed in Shanghai, for example, is that our lung cancer resection volumes, you can see here, are hugely increasing over the last 10 years. And we're doing some analysis on these numbers, but one of the key factors is self-screening. A lot of people in Shanghai are self-screening. They have these detected lesions. It goes to an MDT, and you can see the big increase in surgical volumes as an indirect result of people actually going for self-screening and having these suspicious lesions being detected. Now, one of the byproducts of this self-screening and these increased surgical volumes is increased demand on services. So in Hong Kong, we recognized this over 10 years ago, that with more people having these incidentally detected asymptomatic nodules, there's going to be a bottleneck where everybody is going to have bronchoscopy or a CT-FNA, and that's going to cause a lot of delay, which is not desirable. So many years ago in Hong Kong, we've already gone for what we call one-stop management. So if you have a lesion that we detect, and if it goes to an MDT and it's determined to be a high-risk lesion, we bring this patient one stop to surgery. We offer surgical intervention in one stop without the biopsy bit in the middle. And we do frozen section on table, as we just described. Now, if we do this kind of strategy, what did we actually find? Well, the thing is, we found that the benign resection rate, this is actually quite an old study, at that time was less than 8%. And tellingly, none of the patients complained. They actually were grateful to know that they only had a benign lesion. Nobody had any mortality or significant morbidity from the surgery. So it's actually quite safe to do. But in the meantime, what we gained from that is that the number of patients, the proportion of patients who had significant delay between presentation and surgery, we could significantly reduce that. Now, ideally, what this translates to is better survival. You catch the lesions quicker, you have better survival. Of course, our numbers in Hong Kong were too small to have a significant result here, but you can see a sort of a trend for separation of survival curves. But don't take just Hong Kong's data for that. Another presentation given a few years ago looked at over 690,000 patients in the National Cancer Database in the States, and they identified what could actually give you better prognosis. And one of the factors they found was same-day diagnosis and treatment was associated with reduced risk of death from lung cancer. And that's exactly what we're trying to achieve by doing the one-stop strategy frozen section treatment for these lesions, so you could diagnose it and immediately treat it on the same day. So maybe in future, you can prove that by streamlining your services for screening detected lesions, you are probably improving survival overall. So my last slide, so these are the 3 points. I think in terms of definition of high risk, I think what we need to recognize from China is that there are going to be regional variations in different parts of the world. I think in terms of screening detected lesions, is overdiagnosis a problem? Probably, but the counter argument for that is, instead of overdiagnosis, are you undertreating patients? And there is a school of thought that says VATS 3.0 is something we should be thinking about. In terms of challenges in implementation, I think self-screening is something that a lot of people probably can be thinking about at the sort of healthcare authority level. And certainly as we get more and more lesions being detected by screening, we need to think about how to streamline services. And I've just given just one example in terms of the one-stop strategy. So that's my presentation. Thank you very much.
Thank you. Thank you very much, Alan. And so it was a very interesting your presentation, because we have highlighted the different aspects of lung cancer screening all over the world, in China and in Europe. Now there is a small change to the program, because the next speaker will be our infectivologist, Emanuele Nicastri from Spallanzani, Rome, who is busy with COVID, so we have to let him speak before the others, so sorry. So Emanuele, he will speak about COVID-19 and lung cancer screening, the infectivologist view. Thank you very much, Emanuele.
Thank you. Thank you very much for the invitation. I'm an infectivologist, so I apologize for my presence here among different specialties, but probably the current pandemic COVID epidemiology cannot is needed to be present among this presentation. So my talk will try to speak about the lung cancer screening during the COVID pandemic. So we see a drastic drop in cancer mortality along the last 20 years. But during the first months of the COVID pandemic, we have the result of a very low decreasing number of cancer screening that dropped almost 19% in the standard cancer screening and 84% in colorectal cancer screening. If we see the decline, the number of new cancer diagnoses, we see a 65 incidence lower number. And we can see a drop in melanoma and a drop in lung cancer, about 50% in the last 6 months of our pandemic. If we use the National Health Service System data, we can see an increase in colorectal cancer death, an estimation of increase in the next year, and 5% increase, an estimation of lung cancer death. And in addition, there is a concern about patients to visit healthcare facility during this outbreak only to perform routine cancer screening. So I'm not sure that the current strict infection control and prevention measures that are now in place in healthcare facility that can allow to overcome the fear, because most of medical surgeons are now involved, at least in a more affected country, to manage patients with COVID-19. So we can have, for example,
Emanuele, could you please move to presentation mode, because now we see the other slide. So if we may put in oh, okay, great, thank you.
Yeah. This is an example, for example, for colorectal screening. There are different steps of stop, of delay at FIT screening, at colonoscopy screening, during all the process of therapeutical and treatment screening. And we can see here the estimation of a reduction of survival according to the different stage of diagnosis that are estimated in the next years of follow-up. And this is again an example from colorectal cancer screening in Denmark of an important reduction here in March during 2020. But this is a reduction that was not so heavy like probably it was in a country more affected by COVID, in Europe, Central Europe and Southern Europe. And this is the estimation given from pooled data from meta-analysis of different work of colorectal cancer. And you see if there is a 6-12 months delay in cancer screening, you start to have a 5% relative exchange in increase of death. And this difference start to be significantly increased, more than 12, if the delay became more than 12 months, more than 1 year. And probably we are approaching this worst scenario, at least in most affected countries. So this is what's happened in probably the most important Italian reference center for cancer. And in case of patient with the respiratory symptoms, but probably this is everywhere. So in case of symptomatic or asymptomatic, the presence of positive nasopharyngeal swab ask for a delay of treatment. And the same delay is needed in case you need surgery until the nasopharyngeal swab is negative. And here there are two different swab negative. In the United States, again, you can see how the cancer screening has been reduced in the first years, in the first week, calendar week of this year for breast, colon, and cervical cancer. Lung is exactly the same. This study is an estimation of the impact of COVID pandemic of all cancer death in UK. It's a national modeling study. This is the current, is the common situation in scenario A. This is scenario B, when that is include a reduction of the capacity only in the first 2 weeks of wait before emergency presentation, but with the normal current daily life in the following months after March. And this is the worst scenario that include a reduction during the first 3 months and a partial reduction during the following 6 months, but a new surging capacity during the last 6 months. Probably the current scenario is even worse than what these authors image. Probably we are in a scenario D that is worse. Probably this part will continue. The medium scenario of the scenario C will continue all over the next months. And these are the estimation here, for example, of additional cancer death according to the different scenario. And here you can see the worst scenario, but probably we are in, it was an optimistic estimation given by UK colleagues. And you can see here the number of years of life lost. This is the data from Massachusetts Hospital about non-lung cancer screening and lung cancer screening. You can see here during the calendar week how much it was reduced during the first wave of COVID pandemic. And you can see here compared to the annual study or the initial baseline here, always according the number of calendar week. And here again, from a consortium of 8 hospitals in the United States, you can see here the lung cancer screening, how does how they was reduced during the first months of this year. I don't want to lose time. Probably you know much better than me how to do the screening. These are the different current guidelines how to manage solid lung nodules, and this is the endorsement by the American College of Radiology, American Thoracic Society, how to manage the screening during the COVID pandemic. And you can see here from 1 to 12, all the different scenarios that they quoted. And you can see that up to the item 8, there is a strongly agreement to monitor and delay and monitor the surveillance on solid node up to 8 millimeter with a probability of malignancy less than 10%. So probably this is the opinion of colleagues or experts on this topic during the current outbreak. I'm not sure that at that time they considered that the outbreak can be maintained at the same viral circulation. And I'm not sure if they will maintain the same quotation for each of the item of the different scenario, considering that this outbreak could be maintained for years, according, for example, to international expert on COVID. So, my take-home message are this: cancer screening, there is a concern about patients to visit healthcare centers. Most experts suggest to delay cancer screening until the nodule is less than 80 mm with a low probability to become a malignancy. The incidence of cancer screening has been reduced during the first months of this year. Diagnosis of lung cancer has been dropped about half during April 2020 compared to the previous year, and there is an estimation of between 8 and 9% of death from breast cancer during the next 5 years. Thanks.
Thank you very much, Emanuele. A very nice presentation. You have point out some critical issue in lung cancer screening. Maybe as a surgeon, we understand there is a big problem for our patient, but now I have showed how big is the issue. Okay, so now I ask to my friend Maurizio Infante to speak. He will talk about the management of screening the lectin nodules. Grazie Maurizio.
Okay, so thank you very much, Giuseppe. Today I'm going to talk about this topic upon request of my friend Giuseppe, and I will do it from a perspective of the audience rather than for the benefit of a panel of experts who already know basically everything about this. So many of these concepts we have already heard about, and so I'll be going quickly through them. For example, patient selection, we have moved forward from fixed selection criteria to risk calculators. The most commonly used one is the PLCO, but there are quite a few. The PLCO model is the best known, but there are some 17 of them. All of them tend to outperform fixed selection criteria in choosing the right patient for the screening. But then when you screen, then you find nodules, and you have to be able to handle them properly, clinically, otherwise you end up into trouble. I fully agree with what Matthijs Oldkirk said about volume doubling time, but let's go further with this. Obviously, the definition of a positive test is of utmost importance from a pharmacoeconomic point of view and from a clinical point of view. And of course, we are looking for better ways to handle these nodules, considering that in a non-academic center or in a broad program where people who are involved may not be experts, there may be a lot of trouble in choosing the right attitude. So risk calculators and managed protocols are essential because, as you have seen, shape and volume and density and so are not infallible. You cannot really rely on the aspect of a nodule as it was traditionally done. You have to have workup protocols and possibly biomarkers. So we all know that size matters, and we have learned that by simply increasing the threshold, either diameter or now volume, we can just avoid a lot of useless CT examinations with the consequent downstream investigation, stress, and so. So just by choosing somewhat larger nodules for workup, we're going to have a net benefit for the patients, for the screened population, with little lost to early diagnosis. And you can see that by using managed models, all these management models and protocols tend to outperform the attitude of just sending, referring any nodule which is larger than X to someone. Landgraf in the national screening trials, you can see that the positive and negative predictive values are much higher by using Landgraf, which they did not use actually. That's not the only one. You see the Brock model is another very popular one, and also the Pan-Canadian model performs just as well as the Landgraf apparently in selecting the appropriate patients for further workup, not to identify risk patients, risk subjects to undergo screening. And then we have the volume-based assessment, which is the relative novelty of these years. It looks like the best possible one. Of course, it's not without problems itself. First of all, it's time-consuming. So not every radiologist in community-based hospitals will be willing to adopt unless they have time and the equipment, necessary equipment to perform volume calculations and VDT calculations, which is not always the case. For example, in the Dante trial, we do not have this opportunity. And another small problem is that sometimes volume calculations are not consistently the same. So you can have some variation for the same tumor, the same nodule, on the same patient every day. So it can vary substantially, especially for some, the intermediate range nodules, which are the most suspicious and the most difficult to handle, that is 8 to 15 millimeters, which they have a substantial risk of lung cancer, but not as high as the larger ones. And you see that even volume software packages will perform differently in the same patients, and that would remarkably change the attitude toward that patient. So, but by and large, volume-based assessment is the best possible one, and it is being adopted by basically all academic centers and all screening programs worldwide, in Europe, in the UK, and even Landgrad's version 1.1 has embraced the concept that not only diameter, but also volume of the nodules should be taken into account to recommend the further steps. This is also the Canadian International Lung Screening Trial model that is also based on risk index, Brock calculator, and they're trying to see whether prolonging the screening interval after a negative baseline scan can be useful. We have already heard that from Ugo. Okay, the next few slides I have to credit David Yankelevitz to show how the different management protocols look like. And you see there is some variation, either 3 months, 6 months, PET yes or no, but basically the concept is always the same. Depending on the risk that you attribute to a specific nodule or patient, you either screen 1 year later, or you shorten screening interval, or you move on to higher level investigation, which means, for example, PET scan, bronchoscopy, transbronchial biopsy, percutaneous, or surgical biopsy. And of course, you have to take into account that some nodules do not progress substantially. It was very interesting to hear Alan Seho talking about one-step management directly to operating room, but okay, we could actually argue a little bit about that later. By taking into account that some gram-loss nodules do not progress in the Western countries, the attitude towards recall is quite mild. We don't jump on those nodules, unlike in China. And here you see why in Asia, as we have heard, there is a larger proportion, much larger proportion of nodules that appear like ground glass nodules and are adenocarcinoma. And in a substantial proportion of patients who undergo screening, most of them voluntarily. As I said, you cannot tell by looking at the CT scan which one is cancer. For example, all these nodules, according to any protocol, except one maybe, would have been referred for further workup, okay? You would tell this is a cancer, but this might be, but unfortunately, none of them was except one, this one. So we started, we heard a little about the use of PET scan to handle nodules of that kind that we have seen. But in our opinion, and not only in ours, it has been shown that the addition of PET scan before going to surgery will substantially reduce the number of inappropriate surgical procedure. Inappropriate means that you go for a cancer and you don't find it. This is the results from the Danish lung cancer screening trial, and apparently the best combination would be volume-based evaluation plus PET. If either one is positive, then you have the best area under the ROC curve. And of course, the number of, let's say, futile surgery following a false positive test was substantial. We have heard outstanding advancements with numbers, percentages in the lowest rate, close to 0 now. But in the beginning, it was not like this. The Dante trial had something like 20% or so, but also the early experience of the European Institute of Oncology was about the same. The Nelson trial is over 25%. And so. So Manchester, they're doing a fantastic job, but look at how many inappropriate resections were done in previous studies. And you can see from this old slide that I still have that the addition of PET brings it down. So there are two factors in my opinion. One is multidisciplinary management, including a surgeon who has experience with screening issues. And the second one is availability of PET scan and of a good interventional radiology. And you can see from the following slides, this is the results of the Dante trial. We have obviously published the whole series, including the early phases of the project. But after we got hold on a PET scanner in the hospital, and we started using it extensively, you can see that the percentage of inappropriate resection actually went down dramatically. And so this was also published by a fellow of mine. Also, when we handle nodules, we have to acknowledge that nodule does not stop with the diagnosis. Nodule management will continue after diagnosis, and we have to treat these patients somehow. So we need to acknowledge that they are not all the same aggressive. As I have shown here, there is a whole spectrum of aggressiveness, and we can assume that 1 out of 5 will behave in an indolent manner. This opens the door to various options. Ugo Pastorino and his group published several interesting papers about following up ground glass lesions. This was an example from our institution. This has been followed up and it has progressed, of course. It can happen. But look at this one. This has progressed as well, but it took 9 years, still stage 1. So what if you detect one such lesion in an 80-year-old? Look at this one. It took another 9 years. So they do progress, but they can progress. But if they are detected at a late age, then management could be different. So this is another example. This patient is 60, she's been followed. You're gonna get high-risk patients. Of course, you might argue that you should not screen such patients, but you will get them if you screen a population, maybe not as bad as this one, but you may end up having to treat borderline patients. Okay, the standard is lobectomy, but we have already heard that sublobar resection might be an option for ground glass lesions or for frail patients. But of course, at a cost, we need to acknowledge that wedge resection may be plagued by a high local resection rate, and which will impact on survival. This is because of this phenomenon, STAS, that you have heard about probably. So segmental resection is gaining ground and acceptance as an alternative. And we have heard Julia talking about this. This is, for example, a segmental resection ready to be accomplished in an upper lobe. The veins are blue and the arteries are red. And this would be a good option, a compromise option, of course. Lobectomy is the best as far as we can tell now. We are still eagerly waiting for the results of the 2 randomized trials in Japan and in the States. But we can actually consider it if we believe that the tumor is not so aggressive and it's pretty small. And as we have already heard, minimally invasive surgery is now the standard for screening detected cancer because of its proven benefit in the early postoperative phase. Or the robotic, this is our robotic operating theater. And okay, with this picture of a young Dr. Infante watching the slides of the early Dante trial patients, I hope you enjoyed my talk, and thank you very much for your attention.
Thank you very much, Maurizio. Now I ask to Dr. Rosa Stella Principe from San Camillo Hospital to talk about smoking cessation program, the San Camillo for the Knee Experience. Okay, so we move to Sri Subramanian, that will talk about the value of ENB technology in lung cancer screening. Thank you, Sri.
Thank you, Giuseppe, and thank you for inviting me and giving me this opportunity to speak today. My name is Dr. Sri Subramaniam. I'm the Medical Affairs Lead for Lung Health Medtronic EMEA, and today I'm going to be talking about the value of electromagnetic navigation bronchoscopy technology in lung cancer screening. Just to give a bit of background, cancer causes 1 in 6 deaths worldwide and more than 1 in 4 deaths in Europe. 1 in 5 of these cancer deaths in Europe is due to lung cancer. And despite it being a largely preventable disease, survival rates are not only low, but vary significantly. And in Western countries around the world, the 5-year survival rates for lung cancer average of about 15%. These poor outcomes stem from a number of factors, including late diagnosis, poor access to treatment, and a mixture of stigma and fatalism. In Europe, mortality from lung cancer is nearly equal to the mortality of breast, colon, and prostate cancer combined. So today, I really want to talk about, you've had many presentations on lung cancer screening, and we have discussed really the implications of identifying high-risk patients and those risk factors of smoking, the low socioeconomic class, having a family history of lung cancer, and also environmental factors like radon. Lung cancer, we know, if diagnosed at early stage, at stage 1A, has a very high chance of survival of 75%. And therefore, we need to shift the stage, because currently we are identifying patients who are symptomatic, and we need to be identifying patients who are asymptomatic, and we need to look at risk factors as discussed. And one of those opportunities is to do low-dose CT scans, which will increase the volume of patients needing medical expertise. Low-dose CT scans will identify more sub-centimeter and centimeter nodules, those of greater than 5 millimeters in diameter. And nodule management protocols will become critical following regional guidelines such as the British Thoracic Society. And as has been explained today, LungRADS is an automated algorithm that classifies the nodule in terms of risk by a traffic light system and automatically puts them into categories of red, amber, and green, and will put them into a referral system. So nodule management and EMB, electromagnetic navigation bronchoscopy, offers a minimally invasive biopsy of any lung nodule, and it offers you to have the tissue. So, you know, when I was at medical school, we were always told tissue is the issue, which means that you need to have the tissue under the microscope to definitively diagnose whether there is a cancer or not. The EMB is suitable for patients with poor lung function, multiple or bilateral nodules. There is a very low risk of pneumothorax, and this has implications for hospital stay. It allows access to the entire lung field and can be done as a day case management. It also offers the opportunity to do on-the-table decision-making if things like ROSE and pathology is available on site. It can be used by thoracic surgeons and pulmonologists. And we have proven in a BMJ paper the cost effectiveness of ENB versus transthoracic needle aspiration. And not only does it have great diagnostic capabilities, but it also has, in the future, a potential therapeutic option through microwave ablation. Medtronic has developed the Illumisight platform, which now allows for continuous navigation, reduced CT to body divergence, and increases diagnostic accuracy and improves diagnostic tissue viability. That is my talk today, and I'd like to thank Giuseppe Cardillo for inviting me to speak. Thank you.
Thank you very much, Sri. Thank you very much. I don't know if maybe I think that Rosa will come to my office to take the presentation, so we can instead in the while we can have some question, and I would like to have one question for all the speakers. That is easy. Okay. Dr. Stella is here, so he will have the presentation for my position. So, okay.
I am a pneumologist, and I manage a smoke-free center since 1919. And so, excuse me, and now in this moment, my smoke-free center is in the pneumology unit. It's important that all doctors should recommend quitting tobacco products to all tobacco consumers. The efficacy of a brief advice, 3-5 minutes from a doctor or other health professional, leads to an increased long-term smoking abstinence ratio, level of evidence A. So the 5-ask model is an evidence-based approach to increase smoking cessation. The 5 asks are at the beginning, all the patient if they smoke. It's important. If yes, recommend to stop smoking. And this is a very brief advice with 4% to results in oppose of only 2% when the smoker try alone. So it's important that all doctors use very brief advice. Then there is assess, attempt if the quiet at this time to stop, yes, okay. And then it's important to use recommend pharmacotherapy and behavior support. And in the end, arrange a follow-up. This is fundamental. But it's important to know that we have nicotine receptor. Nicotine binds predominantly to nicotine acetylcholine receptor in the central nervous system. And the primary receptor are alpha-4 beta-2 and nicotine receptor in the ventral tegmental area. After nicotine binds to the alpha-4 beta-2 and nicotine receptor, the result is a release of dopamine in the nuclear accumbens, which is linked to reward. And so, but not only in dopamine, we have the release of many other neurotransmitters that are important for memory enhancement, mood modulation, appetite suppression, anxiety and tension, and reduce the anxiety. So nicotine withdrawal symptoms are caused by suddenly stopping nicotine supply. Nicotine withdrawal can manifest itself in the first 4 to 12 hours of stopping smoking, with the symptoms uncontrolled need to smoke, craving, anxiety, increased appetite, difficult concentration, depression, headaches. Thus, the best strategy recommended by whole smoking cessation guidelines for treating nicotine dependence is to combine pharmacological treatment with psychobehavior therapy. And the brain gets used to prolonged nicotine stimulation and is no longer able to perform the same activities without the use of nicotine. So we must think in terms of pathological dependence on tobacco instead of vice. And in fact, there are 300 to 400 times more nicotine receptor in the smoker's brain than in non-smoker to have the sensation of pleasure and to reduce tolerance. So, but it's important also the genetic difference. So genes that influence the number and the function of dopaminergic receptors and dopamine metabolism. So the fact that the smokers are different in their susceptibility to becoming addicted by mean that the effectiveness of the therapy also varies from subject to these some factors. So what do you do in a specialist smoke control office? Evaluation of smoke-related disease is very important. CO experience measurements, motivation, addiction, select of an effective treatment, and regular follow-up at 3, 6, 12 months from the date of cessation of smoking. So breathe CO is very important to the motivation because they reduce during the meeting and it's very important for the motivation of the smokers. And it's important to value the motivation questionnaire. If it is very low, it's important to use also the counseling therapy. And we have psychologists and psychiatrists in the center. But it's important also the Fagerström test. Fagerström test for the nicotine dependence, if it is very high, it's tobacco dependence, it's important to use a strong pharmacotherapy. And the pharmacotherapy treatment in Italy, we use bupropion, nicotine in gum, inhaler, lozenges, nasal spray, patch, varenicline, and in the end also cetirizine. Varenicline estimated abstinence rate, it's very high, 33% after 1 year is the better in this moment. And what is the mechanism? Nicotine from a cigarette activates nicotine receptor. And so we have the dopamine from the neurons. And during the prolonged period of nicotine abstinence, we have a reduce of dopamine and withdrawals, and we have withdrawal symptoms and craving. So varenicline both blocks nicotine receptor, so reduce reinforce effect from nicotine and produce moderated dopamine release, and this reduce craving and withdrawal symptoms. Bupropion is important because it reduces the reuptake of dopamine, and so we have dopamine for a long time, and so this reduce the abstinence and withdrawal symptoms. So in the end, we have nicotine replacement therapy. It's important to use also this during the reduction of the number of cigarettes. And in the end, we have cetirizine as a treatment for smoking cessation. This is a natural galenic from this plant, Maggio ciondolo, and so it's important to repeat during the day this table. Ugo Pastorino in the past use citizen, and so it's a very important drugs because it's a very cheap. In the end, we have cognitive behavior therapy. This is important because learn to anticipate and avoid temptation and how to trigger situation. It is a collaboration relationship between doctor and patients. In general, we have psychiatric or psychology in the center. So a word on the e-cigarette and the IQOS. No evidence or efficacy for smoking cessation. So in view of the absence of studies, health professionals should not recommend this product. But in the smoker center, we use reduce with e-cigarette and to stop also for the use of this e-cigarette. So it's important to recommend the smoker to stop definitely. In conclusion, the Smoke-Free Center offers personalized treatment based on selective scaling and use both pharmacological and cognitive behavior therapy with individual or group meetings. In our Smoke-Free Center, the course consists of 2 phases, one of a cessation and the other maintain smoking abstinence. During the first phase, and once meeting a week until smoking cessation, general 5-8 meetings, then once meeting a month for a year from the date of quitting to reduce the relapse. We have 40% of cessation for 1 year. Thank you for your attention, please.
Hello, thank you very much to Dr. Stella. Okay, can you hear me? Okay, so thank you very much to Dr. Principe. Thank you very much to all the speakers. So I think that we are late, but I have just one quick question, and I don't know who likes to speak. My simple question is the lung cancer screening worth the money, and why in Europe is not so implemented by the politicians, I mean? So no, I don't know who is able to speak, but just a very quick answer because we are late.
Well, perhaps I can jump in there. I think as I was showing in one of my slides, I think one of the alternatives we found in China was that it's who pays for it. One of the things is to make it cheap enough that the patient pays for it himself. Every time you have the government or health authority or any institution thinking of how I'm going to finance it, it stalls. There's red tape. But what the effective plan we found in China is that just make it cheap enough, $50. Anybody in the middle class can affect it, and they can speak to the doctor to see if they should be having it. But that's one way of getting around the financing.
Maurizio, you want to give your answer to, you say, a very cheap screening, $50 per screening can help everybody to have the screening in a simple way. So nobody has to pay except, but I don't know if it's possible in Italy.
Well, in fact it is, and there are people who do it. The problem is that when you find something wrong, then you will have a downstream investigation and management that is going to be charged on the national healthcare system normally. So someone has to pay, basically. It's not free, if you think about it. And also, you need to prove that it is cost effective by proving that it is saving lives and not only increasing the resection rate. So that's, for example, in Asia, it's because we have seen so many ground glass nodules that may or may not progress. We don't know, actually, we don't know. This needs to be proven whether it is cost effective or not. I'm not saying that it is completely insane, but because if you find a ground glass lesion in a 45-year-old, well, there's plenty of time for it to progress, if it will progress. But basically, you don't know.
I understand. I agree absolutely. Doing a screening is not only a question of doing a CT. Doing a screening means that there is a job behind that check all the report and follow up the patient and see the nodules, how do they appear. So it's something that is much more, I think. So it's not simple. Anyway, I would like to thank all the speakers for the presentations. I think we are a little bit late, but it's okay. I think that if there is no other question, we can close the lung cancer screening webinar and say hello to next April, where we hope that we can have an in-person meeting and we can discuss each other. That is, for in my opinion, much better than to discuss by by a PC. So I thank you very much again. I thank all the speakers. Say hello to Alan that he is late. Maybe it's time to sleep for you, Alan. I know, we know very well. So hello to
it's
everybody.
almost 1 a.m. No problem.
Sorry.
It's just a normal. It's a normal night for me.
We hope to have a nice dinner in Rome when we have the in-person meeting. Okay. Bye to everybody.
Thank you very much.
Thank you. Bye-bye.
Bye. Thank you.
Bye.
Bye.
Nice to see you.